All right, well, welcome everyone. So just a couple of standard announcements before we start. This will take about 45 to 50 minutes, and then we'll have 10 to 15 minutes for questions at the end. We'd appreciate for all people besides our panelists to have your mic off and to have your mic muted and your camera off throughout the webinar. This will be recorded and available on YouTube if you have to step out early and you want to watch it again. And if you have any questions at all, please post them in the chat and we'll go over these during our time for questions. And so we just want to say thank you for joining us for the Building a Comprehensive Pediatric Oncofertility Program, a panel discussion. So today's webinar will be focused on building a pediatric oncofertility program. It's my pleasure to introduce these amazing panelists. First, we have Dr. Karen Burns and Dr. Kara Goldman from the Systems Optimization Advocacy and Resource Committee, which we call SOAR. Dr. Julie Rios from the Startups Committee, and Stacy Whiteside and Olivia Frias from the Patient Navigator Committees. Dr. Leena, Nahata, and myself will be our members of the Children and Adolescent Committee, which is also known as PIN, and we'll be moderating this webinar. A lot of us have struggled with the same issues when starting an oncofertility program. So we've collected common questions from the Oncofertility Consortium members about starting or expanding an oncofertility program and hope that this webinar will provide answers and guidance to newer programs. And with that, we'll move forward with the program. So the first question will be directed towards Karen and then Stacy. And this is, how do you garner buy-in from administration and other colleagues about the importance of a fertility preservation program?
All right. Well, first I would say thank you to everyone for joining and Allison for the nice introduction. I think for us, some of the biggest things we've used and that I've seen other places be able to use to garner support. First would be the guidelines that, ASCO and ASRM were really very helpful to all of us trying to start fertility programs when they published their guidelines a few years ago now, really making this kind of a standard of care option or requirement for programs. And I think also to garner buy-in, I'm trying to keep this short and brief, but to garner buy-in, we really tried to partner with oncology. Having, obviously me being an oncologist made that kind of a natural bridge, but really building that relationship with all the different aspects of oncology to really work in parallel with them and to make it a team effort to try to take care of this patient population. And then once we got going, and we started to have some patients come back and with their stories and being thankful that we were able to offer this and able to talk about it, that really helped us really go that extra mile and get those last people on board with support. Because I think we can talk about it all day, but once you have that patient come back and say that this was really important to me, and I'm so glad that we were able to do it, that just went, I can't even explain how much support that helped us garner. That was huge. Turn over, Stacy.
I agree with Karen. We definitely have a wealth of guidelines now behind us to justify and say, these programs are necessary and here's why. I think the two things that we did that helped us be very successful. One, we found a sympathetic administrator who really got behind the cause and really felt like, whether this makes money or not, this is the right thing to do for patients. Patients want this, and this is really super important. And she really helped drive things forward in the beginning when, there was a little hesitancy with administrators more so buying in. I think clinicians sort of understood what we were trying to do, but administration was a little more hesitant, and having one of their own who really kind of pushed things forward really helped. I think the other thing that really made a difference was we did our homework. We knew the local landscape, what other programs in Ohio were doing. We were fortunate to have, Cincinnati Children's right down the road. And we could kind of say, you know, if we don't do it, we're going to send our patients down to Cincinnati because it needs to be done. And so, you know, we looked around, we looked at all the markets around us, Indianapolis, Cleveland, Toledo, you know, and kind of said, this is what other hospitals are doing. This is how they're doing it. And if we want to be, you know, competitive, if we want to be servicing patients the way other top, you know, institutions are doing it, this is a program that we need to have. And I think that really spoke a language that people who are in charge of dollar signs really, you know, took to and understood. And so I think that made a big difference too, just kind of doing our homework and knowing the landscape of what other programs are providing.
Thank you both. The next question actually is to both of you as well. And that is, who helped create your business plan and how did you identify and justify FTE's staffing needs? For example, having a RN versus a social worker versus a nurse practitioner, etc.
So I think when we first started building our business plan, we really looked to our division leaders, the people who already had experience with business plans, because I certainly had no idea how to do it when we first started out. And I think like in terms of growing and how we justified the positions, I mean, I think it's easy to look at our team now and say that we have these full-time positions and, you know, all the different members, but we really didn't start that way. I think initially it was really about identifying both the people who had the passion for doing this, who were willing to kind of give that extra time and that extra effort, as well as looking at what resources we already had available and building off of that. So, for example, we don't have social workers specifically on our fertility team because we have them in oncology. And so we use our oncology social workers whenever we need that connection instead of building that into our team specifically. And when you look at some of the other players on our team, like our navigator, for example, you know, didn't start out full time, really started out with a very small percentage of our time dedicated to fertility. And obviously Olivia is on this call too, so if she wants to jump in here, that's totally fine with me. But just kind of you went with like a proof of concept sort of model. And as we proved that we were going to be able to do this and be able to grow and be able to be successful, we were able to gradually increase the amount of time that she had dedicated to the fertility team. And it just kind of went from there in kind of small incremental steps to just keep building. So we would build a little bit, prove our concept, build a little bit more, and build on that. And again, just use the other resources that we have. Like I don't actually get reimbursed or any kind of compensation for doing fertility. For me, it's my academic time that I get as an oncology attending. So really just being creative and using those different resources and doing it gradually.
We had I think we kind of followed a similar process, but we, as far as business planning, had someone from business process improvement come in and develop a business plan, which I think was invaluable. I don't think any of us in any way, shape, or form speak business. There were words and presentations that I was like, I'm a clinician. I don't even know what you're talking about. That there's no way that we could have done, I think, on our own. But that certainly wasn't the beginning. We didn't get business process improvement, you know, straight from the jump. We were kind of also a proof of concept. I kind of, as a nurse practitioner, did consults on the side while I was doing sarcoma patient care. And people would say, oh, I know you know, you're good at talking to teenagers about these kind of things. So can you talk to my patient? And then it became, I was doing it so often that I didn't have time to do sarcoma things. And so then we kind of said, hey, you know, again, how about if I do 0.4 of my time and I do everybody's fertility consult and I do, you know, 0.6 sarcoma, and we gradually increased that. And as we did it, we would say, look, we've seen all these patients, we've done these consults. And then the model that we kind of decided to go with was because I'm an APN, I can bill. And so we could put together with our business plan when we had our BPI person and say, if I do X amount of consults, we can bill this much. And so that's partly some revenue that's coming back to the hospital. Obviously, understanding this isn't going to be a big revenue builder, but then we can also prove downstream revenue with surgeries, procedures, gynecology visits, endocrinology, urology, and all of those things. And so that's what the business process person was able to kind of help us pare down numbers so that we could say, if we see X amount of patients, this is what this looks like in a revenue kind of way. This is what the expenditure is. And then this is how we justify what we're doing. And then we would say, okay, we're doing this, but now this population of patients that we're not servicing yet, we could increase numbers more if we had more FTE time. And so we kind of did it in a stepwise fashion as well. Constantly identifying populations that we weren't yet serving because we didn't have the manpower. And then we were able to say, if we have more manpower, this is what we could do. The other thing is just, logistically, we didn't have another provider who could do it. The physicians couldn't do consults necessarily, they're busy doing all the things that they do. And so, kind of saying, well, this person can step in and do this and save, physician time on the back end. So, again, I think you have to get creative with how you're justifying what you're doing. And it certainly helps to have somebody with some business knowledge to make that happen, because we don't, as clinicians, speak the right language to get administrators to get it.
Well, yes, thank you both. And so I think we all appreciate your experience with this. And I think this is probably the wrong saying, but like Rome wasn't built in a day. And so neither are oncofertility programs. And so I think just the stepwise approach, I think is really beneficial for people to know that all programs have to start somewhere. So thank you very much. And then I'm going to pass it over to Leena for the next set of questions.
Yeah, and just to add in, the hard part about this is many administrators will say, well, show us your volume before we'll give you the support. And that is a very common issue that people experience across programs. So you have to do the extra work before you actually have the time to do it, to show that you have the volume to justify the effort, which is hard. So just building off of that, I'm going to ask Kara this next question. What strategies does your institution use to get consults, prevent missed consults, and ensure timely pre-treatment counseling and preservation? So obviously the time crunch is a big deal in a lot of these situations.
Yeah, absolutely. And, I think that we are fortunate. So I'm at Northwestern. We are directly connected to Lurie Children's Hospital. So we have the kind of building proximity, which really helps. And, there are lots of kind of literal and figurative bridges across institutions here. And it really takes patient navigators, because we have an amazing patient navigator in our fertility center, Kristen Smith. And then the Lurie Children's Group has a patient navigator for fertility preservation as well. So there's a lot of communication that happens directly between the navigators. And I think that it has to be as easy as possible for the oncologists to make that initial call. And so the oncologists have Kristen, on the adult side on speed dial. So a diagnosis is made, Kristen is called, Kristen texts me, can you see this patient today? And so it's that kind of efficient because of that middle person, Kristen, and on the Lurie Children's side, the same idea. And so I think that is, and there's, as was just said, it would be really, really challenging if we didn't have a navigator to do that, because I might be in the OR, I might be seeing patients all day, I might not be able to have those initial conversations. So to have someone to make those initial contacts is critically important.
Great. Karen, do you have anything to add to that?
I will just echo the communication and having your process in place to make it as easy as possible for the oncologist to get the consult. So we have done things like add it to our Epic new patient diagnosis order set, and even something as simple as making it default to yes, so it's an automatic consult. And then not only then if you uncheck that box and say that you don't want it, then we make you tell us why. So it just makes people think about it a little bit more. I think, increase the likelihood that they're going to send that consult through. And then I know in the beginning, and we still kind of do it, but we showed up everywhere. So any patient meeting for any one of our teams, no matter if it was physicians or our care managers or solid tumor or liquid, if you're there, it's really hard for people to forget about you. And so then they start to send you the consult. So you stop interrupting all the time and asking them for it.
Yeah, I think the automated default in the EMR has been really successful for our program too. So just to build on that, Julie, I'm going to ask you, do you have some strategies that you guys have used for expanding your oncofertility programs hospital-wide? So many of our programs start in oncology and BMT and then grow from there. So I know you've been involved with a few programs now. So do you want to talk about your experience with that?
Yeah, I'm going to give a unique perspective in our UPMC at the University of Pittsburgh. We have multiple hospitals that are across that often use different medical record system. So this has been a little bit of a challenge and might reflect some other teams that maybe you guys all aren't in one hospital system or able to communicate. And part of that is just information. So what populations are you trying to reach? Trying to reach those leaders at the various institutions or hospitals you're trying to connect, and making sure they have the contact information for your team, if you have a navigator, how to set up those consults, as well as what services you offer. So then they know what their patients are going to be counseled about. And so I think it's just really important to understand those key players in the patient populations you want to reach, and making sure they know how to get in touch with your program and place a consult, and making sure you can expedite that consult once it comes in.
Awesome. Stacy, do you want to add to that?
Sure. I mean, I think I echo what everyone else says. The easier you make it for the providers to do it, and the more quickly you service, the patient and let them know kind of the outcome, you get a couple under your belt or under their belt, as far as like they've consulted you on patients, it really makes a big difference. I think presenting in staff meetings or anything else with other departments is really helpful. Again, getting your face out there, getting the program out there, and making it easy, and just making people aware that you exist, and making the process as streamlined as possible.
So Olivia, if you can comment on where your oncofertility program is actually housed, and then how does that affect your capacity to serve the needs in other patient populations outside of oncology? So like endocrinology, rheumatology, nephrology, et cetera.
Yes, no problem. So we are housed in our pediatric and adolescent gynecology team. So that is a little bit unique because we do have a PAG program. I know those are hard to come by throughout the country, but it's been awesome to have that support. So my history though was in oncology. So I was able to take a lot of that information with me and blend my brain with the reproductive knowledge I obtained working in pediatric and adolescent gyne. Myself and Caitlin Kastner, we are now both the navigators in the program. So as Karen had stated, we started with just a little bit of, we started with no FT for me, then turned into like a 0.2 and a 0.4, and now we make up about a 1.2 total. But I think when we, expand into other programs, we really have to go back to some of the basics of the strategies we had to use to just get the program going, right? Because so many programs out there are still just trying to even tackle their oncology team, which is going to be kind of the bread and butter of the whole program, right? And so within our Cancer and Blood Disease Institute, we really had to figure out pathways for each individual team within that umbrella to reach out to us. So although back in the day, it may have just been me, I still had to come up with unique ways for people to get a hold of me. It wasn't just going to be an email or the inpatient order set or the ambulatory order set or the pager. We really had to find unique ways that really spoke into those individual teams within oncology. We then could take those ways and expand those out to other programs. And so we had found that, let's say with nephrology, a lot of those patients actually might come in with like an acute need for a biopsy. And then we find out they're starting Cytoxan within, just a couple of days. And so working and educating with that team to figure out, is there time even before they get to that point that we could be having these conversations versus that inpatient consult? And transgender patients, we've really been able to utilize the outpatient consult. And so, like I said, everything does come into a unified point, which is Caitlin or myself. But then from there, we're able to figure out what consults are most acute and who needs our attention. But as everybody, I'll echo again, just really putting ourselves in front of all these individual teams. And the more we do that and go to these sessions and really promote how much we are able to kind of be chameleons and conform to the ways that we need to meet their patients and their populations, and do it in a seamless way and show them the tools that we've already utilized, that's really helped in expanding our team. And it's been that much easier because we've learned so much with working within the oncology team.
That's awesome. It's really helpful. Julie, do you have any different perspectives, again, across the two institutions you've been at, about how you're serving these unique or different patient populations?
Yeah, so I was at Cincinnati Children's before I came here in University of Cincinnati. So I'm going to speak more to UPMC. And some of that history is before I got here, but it was initially housed in our OBGYN department, and Dr. Kyle Orwig was very important in getting our program going with the tissue processing for testicular tissue as well as ovarian tissue. So it almost started with that processing center and then combined with our reproductive endocrinology, or my division, REI. And then we partnered with the Children's Hospital. So currently at Children's Hospital Pittsburgh, it's housed in oncology, and they do all of the fertility consults there. And then if they need ovarian tissue or testicular tissue, or they're an egg freezing or sperm banking candidate, then they'll actually streamline through what we have, a Center for Reproduction and Transplantation. And that's where our navigators and research coordinators are housed to then get our patients to the team that's going to provide their fertility preservation counseling as well as services.
So just to clarify, even though the program is housed in oncology, are there barriers to then doing consults in rheumatology or endocrinology for some of these different patient populations?
So that's where we kind of, we don't have any barriers to connect with them, but we will go through more of the CRT that's housed over in the OBGYN department at our McGee-Wins Hospital. And so those patients come to us and come to me in one of my fertility preservation clinics to counsel them. And we have those clinics pretty regularly, so we can see them in a quick time frame.
Okay, great. Karen, do you want to speak briefly to processes that are in place for ongoing fertility care, like in survivorship?
And I'll just add one thing to the conversation we were just having too. I think one of the things that we did is we have a fertility consult in Epic too, which I think can help some of the other services. So it might feel weird for nephrology to reach out and get an oncology consult in order to like get that fertility information, but it makes it a lot easier and a little less awkward if they're just reaching out and getting a fertility consult, regardless of who's actually doing it.
And I can just piggyback on that. We actually put a pop-up or like a box that shows up in the EMR if somebody orders Cytoxan, because that's often like what somebody was saying is that we get these consults and it was like the Cytoxan was already going by the time we were able to even see the patient. So having that trigger alert based on that drug has been helpful.
Yeah, exactly. Perfect. Then in terms of survivorship, so for one, we start trying to connect with families about 1.5 years or so after they finish therapy, but we're pretty fortunate, I guess, in our program, and that I also do survivorship too. So all of our patients who come through the survivorship program end up talking about fertility again, and we usually kind of will do the education and the assessments in the survivorship program, and then just reach out for a formal fertility consult for patients who are interested in exploring fertility preservation a little bit more. And I think that's taken just some years of education with the rest of my survivorship team to teach them the ins and outs of risk assessment and who's at risk for fertility and what that risk is and what it means X number of years down the line. And I think anybody on my team now, when they come to me with a survivorship patient, it's like the first thing out of their mouths. Like, we talked about fertility and this is blah, blah, blah. And then we go through everything from there. But I think it's definitely important to bring it up in survivorship and have some sort of mechanism to make sure it's addressed again, even if it's for the boys and just reminding them what that risk was. And so I would definitely, if you don't already have somebody from your survivorship team involved in fertility, definitely making that connection is going to make things very smooth in that whole survivorship process.
Okay, awesome. So our next section of questions was really a lot about billing and some logistics related to that. So I'm going to turn it back over to Allison to lead that next section.
So this is a question for Stacy. How do you bill for consults? And I guess you already kind of mentioned that you do all the consults, but how do you bill for consults?
So this has been a process. You know, I was pretty used to billing from being an oncology nurse practitioner. So our compliance and Epic staff kind of built a fertility consult like billing codes. And so that was kind of in place and made for me eventually. An interesting kind of tidbit that I have it's been really like a learning process is oncology throughout the division does chart audits. And so basically they're looking at your charting to make sure what you're reflecting in the chart is appropriate for what you're billing. And they build in a lot of like dot phrases and things so that you have like the right, you know, information for compliance. They did my chart audit and came back and I completely failed. And what we learned from that is that there were particular things with billing and things that I needed to be documenting and ways I needed to be documenting to fulfill the billing. And so it resulted really in a lot of changes as far as things that I was documenting and how I was documenting. It was really disconcerting to get back you know, you've failed your chart audit and now you have to like have counseling about this. And I was like mortified. Having been a nurse practitioner for a long time, I was like, what do you mean I failed? But it was just, they had to tailor kind of what I was documenting. It actually worked out, so I'm documenting less. It's more kind of streamlined and appropriate to a fertility consult versus, you know, like just general, a note that you would write. And so I would, you know, if anybody is billing for fertility services that isn't like an REI or somebody in fertility, I would encourage you to talk with the people who do your billing and compliance and your Epic builds to make sure that all, you know, everything is how it should be and how they can streamline and make it easier for you. Because I found out the hard way after failing a chart audit that there were certain things that the system wasn't anything that I did necessarily, but there were certain things that the system could do to make it easier for me. I just was not aware. So that's my billing experience.
Olivia, do you have any additional thoughts or how doing things differently at Cincinnati?
Yeah, so we, you know, have an interesting model because I cannot, with like my master's, I'm not able to bill. But since I am housed in pediatric and adolescent gynecology, it has been nice because I'll have typically someone on call who can either like go with me or I will go get the conversation started on like an acute, let's say high increased risk patient. And then if someone elects to do OTC, they have to see then the gynecology attending and have a formal consult. So they will get kind of like an educational session with me, and then they get the billed fertility consult from the gynecologist who's going to potentially do then the OTC. I will say that telehealth has been pretty awesome too in the event that I don't have a clinic open that week and we need to get in. Like yesterday, yes, we had quick Ewing's coming in, needs a port and OTC next Tuesday. We have no clinic between now and then. So my attending did a telehealth with her yesterday during her academic research time. So we have to get creative on some of these acute patients, but we also have a fertility consult clinic built in within the Cancer and Blood Disease Institute clinic. I think that presence is like twofold in the fact that we have opportunities to kind of stack outpatient consults. So it works very well with like our elective transplant patients, people that we do have time to work them up. They can see the attending and bill. And it also works well because we've got that presence. So it helps kind of then get into what Dr. Burns was mentioning about survivorship. We can put those patients in there as well. So we have pretty much once a week, a half-day clinic within that setting. For the males, we work closely with our urology program. So if I have a male patient that can be seen by the urology nurse practitioner or RPA. There's 2 designated personnel that help Caitlin and I to see the male patients. If they're urgent sperm bankers, we typically will just pick up the phone call or go straight to inpatient and make sure they're set up, not billing for that, of course. But again, if they are going to then pick to do testicular tissue cryo, they will then get a bill for that consult as well. So I know it's not that it's a perfect, like, easy way to follow for people, but it does give you guys an example of how you can kind of slice it and dice it and get creative.
Thank you. And then the next question goes to Karen and Kara. What billing and procedural codes do you use, and how to submit them to insurance before procedures to ensure patients don't get a surprise bill? And then are there any resources that can help with this aspect?
Sure, I can start with this one. So, if it's OTC, so that's housed under Lurie Children's in the pediatric surgery division, and so that's Dr. Rowell, Aaron Rowell, and typically those procedures are combined with other procedures like ports, et cetera. On the REI side, if I'm counseling a patient about egg freezing, then we will always primarily use their cancer diagnosis code or their whatever their medical diagnosis is that's requiring fertility preservation, because it's unclear, based on what state you're in and insurance coverage, like if fertility care will be covered. And for minors, which most of these patients are going to be under their parents' insurance, we typically have been having great success with coverage because we're in Illinois. So this is for both employer-based coverage as well as Medicaid. And that's going to be so different state by state. And so this is where having someone who's an expert in financial navigation, which is also the job of our patient navigator, they really they're on the phone every day with our insurance companies. And so I think that this is where having a navigator makes it possible, because the finance team often just won't have the savvy to be able to work with the codes in this way and optimize coverage.
Yeah, and I think I'll just echo that. So we will again work with our surgery colleagues to try to combine any kind of ovarian tissue or testicular tissue cryopreservation procedures with something that they're already getting, so that the costs can go together, can go under that. And then our consults are billed as at risk for fertility problems or fertility preservation counseling. And I think we've had pretty good success getting them covered as well. And I know our REI team at UC works pretty closely with insurance to try to determine any potential cost there if we have a patient who's going to go through those procedures.
And I'll add to that, if it's, so a patient will definitely know before their egg freeze cycle if they're going to have coverage or not. And if not, then most REI clinics will provide some really substantial discount. So you're essentially offering egg freezing at cost. So whatever it costs in the embryology lab, this is not revenue building. This is just offering it at cost. And then there certainly are grant programs for people who are in states where there's no insurance coverage.
Mm-hmm. Thank you. Because am I correct when Ohio does not have mandated insurance coverage, but Illinois does? And so I think for people to know what their state information would be really important too when setting up a program. If your state is one of the states that has mandated coverage, and what that looks like, because I think that's different from state to state too. So
yeah, and we did, and we modeled this off of Cincinnati, and I don't know if anything's changed, but we worked with our hospital administration to bring down a reduced rate if somebody was going to be getting the bill for something like OTC. But it's still not a perfect system. We always try to go through insurance, but there are just some issues like processing and things like that have been difficult for families.
Yeah, and I was gonna just add to that too, that we actually do try our best to make sure that if patients are even the slightest bit interested, as soon as I walk away, I'll actually just send their name and their insurance information to our insurance coordinator. We have one that works in strictly gynecology and one in urology, and they are the two people that help to see if it is going to be covered. They typically find out pretty quickly, even sometimes without a note, they'll be nope or yes. I would say we've been 50-50 with the OTCs being covered in Ohio for us, but the TTCs have been almost 100%. So I find it very interesting that they're always like covered. I don't know if it's because, you know, biopsy versus a more invasive yet minimally invasive procedure, but that's kind of, I actually pulled the numbers for the past 2 years, and last year was pretty much split with coverage versus non. And like Leena had stated, we went to the higher ups at the institution to say, at most, this has got to be the out-of-pocket cost, because I need families to at least know at most this is what they're going to get charged. Because when you start adding up all of the things for standard nephrectomy, we know it's going to be just an ungodly amount for them.
I think it's really interesting too. You know, I'm in the same state as Olivia, and our experience has been different than hers as far as like what's covered and what's not. And I know we've talked to colleagues in Cleveland, and their experience and what's covered and what's not has also been different. So much like Gwen alluded to in the chat, even within your state and within different insurance companies, it's really hit and miss, and you just kind of never know. And so I think it's important if you can negotiate kind of worst case scenario costs with your institution. So at least patients have some idea of what the worst case scenario is. And then whatever coverage you get, you know, is great. But it really does vary in states. So I think it's really hard to predict. And I think within, you know, the kind of climate with fertility care in the United States in general, who knows what's going to happen. So I think it's a moving target for sure.
Yeah, thank you for those really great points. And last is a question to Julie. Is OTC and TTC protocol, is your OTC and TTC protocol under an IRB? And what populations do you offer OTC and TTC to?
Yeah, so ours is currently under an IRB for patients that do this within the Pittsburgh area for both procedures. And we offer it to patients receiving gonatotoxic treatment, typically either in the significant or high risk categories that don't have the opportunity to do other things. We also have research protocols for OTC and TTC for gender dysphoria populations as well.
Yeah, thank you. And does anyone have offer OTC currently not under an IRB protocol?
Yeah, that's our situation, and Stacy can.
Ours is not.
Yeah, ours
is not either.
But our TTC is not.
TTC, yes.
Yeah. And because I think it's important because to kind of identify that there is going to be some programs that still have OTC with an IRB, but a lot of programs are having OTC without an IRB, and then, you know, what that looks like. But that would be, I think, a whole separate discussion would be all on OTC and how to do that. So maybe that will be to come. So just to get in the efforts of moving things forward, I will pass the baton back to Leena for our last set of questions. And these are really about how the oncologists or the fertility preservation team can interact as a group with REI and other team members. So.
Yeah, and I do want to just make one clarifying point, is that our OTC is not under an IRB, but we don't offer it to some other populations like Turners and kids who are transgender at our institution. So, you know, I think if we were thinking about that, we would have a different conversation about IRB. So just to clarify that. So this next set of questions, you know, I was hoping to get both Julie and Olivia's perspective about interactions between navigators and REIs to really expedite the process of egg freezing. And then, you know, sometimes when you have to talk to a urologist about sperm cryopreservation and sperm making labs and all of that. So maybe we'll start with Julie and then we can move to Olivia.
Yeah, so in our program, we have the intake nurse navigator who gets the consult. They get information from the referring physician, like how much time does the patient have till they start chemo, and are they going to be cleared to do these things that we're going to talk about, like high estrogen levels and procedures under anesthesia. So we get that information from them. We also get them cost information as quickly as possible, because that does drive sometimes if people move forward with egg freezing. And then that is essentially sent to our physician pool, and we have slots within our clinic that are blocked for this every week. So then we can essentially just move these patients into them. And for the most part, those are filled every week. You seem like 2 days or things right before, oh, we don't have a patient. And then of course someone comes in the day before. So I've always worked in an academic institution for REI. So we've been very blessed to have that as my setup. And I feel like that's really important. And then once the patient is seen with us, we have a kind of roadmap that essentially our nurse team that's going to take care of them in REI communicates with the fertility navigator, and the patient has multiple contacts for resources because they're trying to navigate through their oncology as well, but they're also trying to get medication sent to do their fertility preservation. And so we just make sure that they have contacts with our navigator. But there's essentially like a closed loop. Like when a patient has completed their treatment, our nurses let our navigator know, who also let the oncologist know patient is completed, so that there's not this, oh, can we start the chemo? Are they finished? So I think those loops of communication are super important. And even if a patient, after hearing an egg freezing consult or fertility preservation consult, declines, our navigator then goes back to that referring physician and says, patients decided not to move forward with fertility, you can proceed with oncology treatment. And we do have like a late effects clinic in our institution as well. So we offer that as a follow-up if patients want to learn more about fertility preservation in survivorship or after chemo.
Awesome. So Olivia, can you speak both to the egg freezing and the sperm banking coordination?
Yeah, so I'll start with the sperm banking. So like when I first started doing this, we have always had a great relationship with the University of Cincinnati, and it has just flourished over the past decade. But in the infancy of this program, I actually just like got in my car and drove to every sperm bank in the tri-state area because I wanted to just meet with the doctors or their business director to say, you know, listen to my story. I'm going to be sending you 14-year-old males. You know, what does this clinic even look like? I mean, you get questions like that from your patients. Where am I going? I'm like, am I sending you to the water fountain REI, or am I sending you to the more sterile research clinic looking? You know, like we need to help these patients as they enter into a scary unknown world of heading to the adult clinic. So I actually had some great conversations with this, understanding anything from the logistics and the price points, and you know, having them hear our story that I'm sending you these vulnerable younger patients who, you know, $160 is a lot to them to come up with in 24 hours. And as we built relationships with multiple clinics, just also in terms of like time, like who's open on Saturday, who's open on Sunday, like I wanted availability for our patients, even if it meant going outside of where I really want them to go, if it was like an urgent need. So as that flourished and we got closer with the University of Cincinnati, obviously Julie and I were working together in the background before she even started working at Children's, sending patients, but they were able at the University of Cincinnati to also get a navigator as well. And so that has been amazing to have a patient navigator working on the adult side that can coordinate with Caitlin or myself. I will say that our patients within our Cancer and Blood Disease Institute have a very unique setup where each patient has their own care manager or care coordinator. It's a nurse who takes on over 50 to 60 patients at a time, and they are following their journey throughout their chemo. They're telling them what their calendar looks like, uploading their treatment plans. And so it's very important that I connect with them as well as a navigator with REI to figure out, you know, when is their anticipated treatment, because they are the ones who are going to get the signature on the egg freezing form from the oncologist. And so it really is a great pathway of communication between the patient's oncology care manager, their attending, and Caitlin and myself at Children's, and then working with the REI group. The navigator with the University of Cincinnati has been just fantastic. I can get a hold of her through text or email. And I will say we've started doing quarterly meetings with them too, which has been great. So really helping anybody from meeting with their financial representatives over there to their fellows, to their attendings, to make sure that we're all on the same page. And if there is a patient, you know, situation that didn't go as seamless as possible, what can we talk through it so that they have a better experience the next time? And really just closing that loop with getting results back and understanding that, all right, they've got to go to start treatment now. So really it comes down to the navigators having that close communication.
Okay, great. So if we want to talk a little bit about billing, I know Kara, you had already talked about how things work at your institution with billing, and I think, you know, hopefully getting some help with the insurance mandate. What about sperm banking costs? So Olivia, you just mentioned that. Maybe Stacy, you want to talk a little bit about this, especially given the short period of time that we often have for our patients to bank sperm. How do we handle the costs related to sperm banking?
Yeah, so I think for us, you know, it was like super instrumental to have Dr. Rios with us for a little while to really kind of hit home with the University of Cincinnati for her to realize too just how much our patients, what financial barriers she's really seeing with her own eyes over here with our pediatric patients and their families. And so we worked closely with them to come up with the cost that they felt was appropriate on their end, and as well as for patients and families. And we've been able to utilize that cost now for a long time, and it hasn't had any changes in that. But I will say too that, you know, let's say we're charging around like $160 for, you know, sperm cryo. Even that, you know, I had a patient the other day, he's like, I don't know how I'm going to come up with that in 2 days. And so we try to keep some type of little emergency fund for our patients here, whether that's for raising money through a 5K or pitching to a gift shop to get some seed money to have, but to be able to dip into that and utilize that. So we have been able to use that. I also look to social workers to help me in understanding sometimes financial barriers if patients and families are just a little bit maybe too shy to say, I actually can't. And so I meet with the social workers at least once a year to say, you please help us to understand too, if someone's expressing to you they're having a financial barrier. But I know with all this, cost is can definitely be a struggle. And if we do cover that first cost of the sperm banking, we do make it pretty clear to families though that it's very hard for us to cover any like storage costs for multiple families going forward. And that's something that they do have to really think about and conceptualize, you know, how many years forward is that? And if that doesn't seem feasible, then it really has to be part of the equation when making this decision.
Okay, and then Stacy, yeah, you want to talk a little bit about costs from your perspective?
Yeah, I think we really did things a little bit backwards. You know, we're noticing that families were having trouble paying, you know, not only for sperm banking, but also for cryopreservation, and processing for ovarian tissue. And so I think unintentionally we went to our administration and said, look, you know, we're having challenges with patients being able to take advantage of this service. What can we do as an institution to kind of support families? And, you know, as with most hospitals, it takes time. And then, you know, they got back and kind of said, yeah, you know, as an institution, we feel like we should cover cryopreservation and processing for ovarian tissue. And we were like, great, this is wonderful. What about, you know, young men who are sperm banking? It's you know, a tenth of the cost. It's substantially less. And we're still working through that process. And so sometimes things don't make sense and you just kind of have to take what you can get at the time. And so that's sort of where we stand. We're still kind of fighting for trying to get sperm banking and some potentially some initial storage covered. We have had great luck with some nonprofits here and there that can really turn things around really quickly. But that's been more the exception than the rule. So I think work in progress.
That's great. So I think we can stop sharing, Allison, so that we can have more of an open Q&A. I know Veronica did put something in the chat, which we can talk about briefly about IRBs with OTC. Do you want to, Veronica, do you want to unmute and just speak to that a bit?
I wasn't sure if we were going to have a separate session on TTC and OTC, but if you do decide to do through an IRB, the IRB is going to come back and say this is not research. And so you need to kind of put it as we're doing this because it's standard of care in certain populations. It's not been well evaluated, but we are gathering research, and we're gathering information, and that's the research piece. So that's just something that many of us have run into with scientific reviews and IRBs. And just so you're aware, the OC is involved in trying to create sort of a central database. So eventually that could be how you argue for your IRB approval.
Great. So I don't see anything else in the chat, but we would really like to open it up to all of you who have joined. Feel free to put your camera on and unmute and ask questions of the panelists, or maybe if you want to hear a little bit more about one of the topics we discussed. Gwen, do you want to, it looks like you raised your hand.
Yeah, I have a question, I think, for Veronica about the IRB and phrasing it that way. And then I wonder if you run into issues if you do have this under a research protocol, if in fact then patients are paying, because typically in research protocols, we have to show that the patient is not incurring any additional expenses.
Yeah, that's a great question. So the way we have articulated is that the actual OTC is not the research. The research is that we're collecting data on people who are undergoing this. So technically you could say, well, maybe the OTC is not being done under research protocol, but it's a way of making sure you add to your consent all kinds of information, because the truth of the matter, and again, this was about fertility preservation overall, so I don't want to hog the whole thing with OTC and TTC, but with OTC, there's been one pregnancy in somebody who is prepubertal when they collected tissue. So there's so much we don't know. So I know that it's been deemed not experimental, but I think we all have concerns about that. And so many of us have chosen to continue to do it under our IRB approval because of that.
And I will say, when we moved from it being under an IRB at Cincinnati Children's, they still sign a consent. It's a clinical consent similar to what we use during like someone that undergoes egg freezing, because there are risks associated with things and unknowns, even in egg freezing. So a lot of the language of outcomes and things like that are still in a clinical consent that patients sign for that. So I still think even if you don't do it under an IRB, that you still have some kind of clinical consent so that you're documenting that you've informed these patients. And one other thing I was thinking about as we were talking about this is when we talked about interacting with REIs, I've been at academic institution, CARE is at Northwestern, but there are going to be clinics that don't have maybe an academic REI center that has like a fertility navigator at their center. And so I think it's just super important to like find the local private practice REI, whichever ones are in most proximity, and still interact with their, management and business leaders and physicians to see if you can, establish some kind of at cost egg freezing or sperm banking, and the process of, I have someone that needs to come in quickly for this. How can we do that? Because there definitely are lots of private practices out there as well that are egg freezing and can do this quickly too.
Yeah, I'll say that we work with a private practice who's been amazing, and they offer, they're they are registered with Livestrong and offer significant discounts to our patients and do things at cost, even though they are a private practice group. So I think just developing those relationships is so important, and really just putting yourself, when you're starting a new program, just cold calling people, talking to people, and seeing who is also passionate about this is really going to get you very far.
And that's such a good point, and I'll echo that as well. When you're reaching out to your local centers, trying to figure out who can kind of feasibly and safely take care of some of these really sick patients. A lot of the private groups are going to be in freestanding surgery centers or kind of freestanding clinics, and they just may not be able to take care of a sick patient who's pancytopenic as we would be in an academic center. So really identifying like who you can call kind of in a pinch for some of these really sick and very young patients.
So we have a point in the chat, and then somebody has raised their hand. So the question in the chat really has to do with prognosis and survival. So I don't know if maybe Olivia, if you want to take this, is how do you guys address that or consider that when you're deciding to do a fertility consult?
Yeah, so we came up with, like, in the beginning of the program too, just some like definitions of what is eligible for a consult versus ineligible. And this really took a collaborative effort with oncology, bone marrow transplant, and kind of all sitting together as we wanted to shift the culture that fertility consults needed to happen on all patients, but yet being very clear that we understand that's not true as well, and that we need to identify those patients that it's just not appropriate. And so we came up with some just standard definitions, and it helps too when you're just tracking these with your databases to just keep it kind of clean and cut with whether it's surgery only, palliative or observation. But we also found that, if I'm documenting in a chart that we've heard that, someone has DIPG and it's a terrible prognosis and we know we're not going to see them. I always still reach out to Karen, who is my oncology lead in the program, and then she'll sometimes send an email to their attending to say, hey, we noticed this on a chart review, like we picked this up, is this appropriate? But we also even changed like the way we're putting it in our flow sheet. We've, instead of like having the word palliative, like I just know with my chart and the way of the world and everybody's seeing everything, like I don't want them seeing something from a fertility team coming through that like a patient is palliative and we're not going to see them. Maybe that's not even the case yet. So we just did incompatible with our fertility like consult definition. So I made this little acronym. So if it's like incompatible, then we know that's what we know as a team, that the patient probably has a poor prognosis. So that's our way of kind of, staying clear of putting anything in the chart that's not appropriate from our end, but also having that communication with Karen's been fantastic in making sure she really reaches out. It tends to happen a lot in our neuro-onc patients.
Yeah. Betty, I want to call on you because you raised your hand.
Thank you. I have a site recently who received funding from a private donor who would really like the money to immediately go to patients in need of fertility preservation, but the legal department said that that's just something that can't be done. Do any of you have any experience with that, where you can take on philanthropic dollars and use those directly, immediately with patients seeking fertility preservation?
I can speak to that. I don't know. We have a lot of philanthropic dollars, and we had to work really closely with our foundation and administration and legal and all of these people that some I didn't even know existed, in order to get definitions of who meets the financial aid. And so we actually looked at other programs that our hospital was already offering. And so we wanted to give it to everybody, and they said that could be enticement and different things. So we ended up mirroring it off. There's already something in our hospital system for patients who met certain financial aid criteria to get free breast care. And so we actually used those definitions, and then we're able to say this is already an established program through our hospital system. These are the people we're going to be able to offer this to. And that was really helpful. And once they saw that, they said, okay, we already do that. So perfect. But we had to kind of look and see who would be even something similar in the whole hospital system.
Great
Lillian,
advice. Thank you.
Yeah, I think Lillian wanted to weigh in too. And I think they do have philanthropic funds they use for fertility. So go ahead, Lillian.
Thank you. Yes, we had actually a donor give a nice big chunk of money for fertility preservation for sickle cell patients prior to bone marrow transplant. And I'm telling you, it's the hardest thing to be able to access that money. I've been working on it for so long. And part of it is that they, much like Allison said, you have to offer it to everyone. And that you have to get the REI to agree that if I give you $5,000 for procedures and $5,000 for meds, nothing can be billed to the, to other patients. And this same amount of money has to be offered to every patient with sickle cell disease. It seemed counterintuitive to me for what the intent was. And that was to help people who, like, I thought we should just file for insurance. What's not paid, we can pay for it, but that's not the way it works. The other thing is many of the REIs want money up front, and many of the foundations want to pay it at completion of services. And so we were able to move to an agreement that we would guarantee payment. And but that took about 3 years to get to that point for them to agree to do that. So it sounds great, but it's a sticky wicket. I mean, there are a lot of places to do it wrong. And I think I found all of them, but so yeah, good luck.
All right, Carol, you might end up being our last question because it's 12:01 Eastern.
Great, thank you. So I'm a pediatric oncologist at Children's Hospital of Orange County. And in California, as you may know, we have some issues when it comes to applying for insurance for the coverages. We do have philanthropic funds that help to cover. I just set up things with REI programs so that they can, hopefully get donor funds through that process. But when it comes to paying my surgeons, like the gynecologist for the oophorectomy or testicular biopsy, that's the part that, I had to work with them to see what is the possible fee that they would want to go ahead and do these procedures. I wanted to ask you guys, are any of your surgeons doing it for free, or are you all paying them separately if you can't get the insurance to cover this? And I'm assuming for the TTC, you wouldn't get coverage since it's a research.
I can speak to that real quick. So we, when we first started the very first couple of cases, our surgeons did it for free as we were starting, but now they just offer a reduced price. They say, this is how much we're going to charge every patient, and it's like X amount, and it's all. And so we have kind of like Cincinnati, like we will not charge patients more than this amount. It took a lot to figure out how to get there, and we actually have to end up billing it like we always go through and try to go through insurance first, and then we end up billing it like they bill cosmetic procedures that are attached to general surgery procedures, because those the patients bill for themselves or pay for themselves. And so that's how we ended up being able to like say this is the price that we're going to pay. But
so can I ask you, so that surgical price that the surgeons are offering at a reduced fee, your patients end up actually, if it's not medically covered insurance wise, and they pay for it versus like philanthropic funds?
So for TTC, everything is covered because that was like through IRB. That was we have to pay for that, and we pay through that through philanthropic funds because it is IRB. But for OTC, yes, if it's not covered by insurance, then our patients will have to pay for that. But we have like a max amount that they will pay, basically, which somewhere around $5,000.
Yeah, ours is the same. We basically have that max, and the surgeon fee, if it doesn't get covered, that's the part that the families will have to pay then. Again, if it's bundled with something else, then it'll cover the anesthesia of the hospital, but that outstanding bill, we will then just have that surgeon fee overall, but no more than paying, like ours is between $5,000 and $6,000 for the whole thing if it's standalone and they don't get it paired with anything else.
I see.
And Gwen just posted something about the ethical and clinical challenges of disposition of gametes in among minors, which will definitely have to be a conversation for another day. But I just want to thank you all. Thank you so much to all the panelists for preparing this and working with us to have a great discussion today. As I mentioned in the chat, this has been recorded and will be distributed. And thank you all for attending, and hopefully this was useful and will continue to be useful as programs continue to be built and expanded. So have a great day.
Thanks, everyone.
Oops, and just one other thing. If people, here are contact information for all of the folks on here, if anyone needs to reach out about anything specific. And here's the information if you would like to join, if you are not yet a member of the Oncofertility Consortium listserv and you want to join, or for the Pediatric Initiative listserv, you can email Jenna. And we're looking forward to seeing everyone at the 15th annual conference in Pittsburgh. Thank you.